appreciate everyone taking time this morning to join us for this session of our Health Policy Issues Group, obviously being done by Zoom webinar. My name is Arnold Weinfeld. I'm Associate Director for the Institute for Public Policy and Social Research. And I'm joined today by my co-host and collaborator, Dennis Paradise, with the MSU Institute for Health Policy Issues, and also Executive Director of the Michigan Health Policy Forum. I want to thank our speakers, our presenters, for taking time this morning. Again, I want to thank Dennis, and I also want to thank the Michigan Health Endowment Fund for their generous support of this program. For your information, we have a fantastic lineup of presenters from various disciplines in healthcare who will be talking about healthcare after COVID-19, or as we talk about the new normal. I'll hand it over to Dennis here in a second as he'll be moderating, but just to let you know, as participants, you are all muted. If you have a question, please feel free to ask it in the Q&A box, and Dennis and I will be monitoring that. So with that, I'm going to turn it over to Dennis. And again, thank you everyone for being here.
Arnold, I thank you, and I thank all of our participants today. As the country starts to reopen from the COVID-19 shutdowns that we experienced, we're getting a variety of different reactions. I was just reading this morning that Oregon is reinstituting a shutdown procedure. Arizona is being hammered by COVID-19, but it just decided not to reinstitute shutdown procedures. So we are going forward in a variety of different ways. And the purpose of today's seminar is to tap on the expertise of a broad range of healthcare professionals, both from health finance and healthcare delivery, to talk about what we in Michigan are going to encounter or expect to encounter, both directly as a result of COVID-19 and indirectly as a result of COVID-19 shutdowns and other factors. First, let me tell you what we are not going to do today. We are not touching on one of the most embarrassing aspects of COVID-19, and that was the disproportionate share of morbidity and mortality that fell upon the African-American community. And we've not asked our speakers to focus on that this morning because we are going to do a healthcare forum in September that is dedicated to that. And Arnold, if you could bring up the first slide, it will show you that the topic, racism, the epidemic behind the pandemic, is scheduled for September 14th. If you are not on the Health Policy Forum mailing list, you can Google Michigan Health Policy Forum. It will give you the cover page. You can sign up on the cover page, give us your email address, and we will invite you. But moving on to what we are facing now. Arnold, can we do slides, or shall I just do a narrative?
Let's see here. Do the narrative. I'm working on bringing up your slides all of a sudden.
Okay.
Having issues here. So.
In terms of where we are now, well, here's the executive version. We've stopped the wildfire. That's the good news. The not so good news is the wildfire has distributed embers throughout the state of Michigan, and each of those embers would be more than happy to turn into its own wildfire. So while the good news is we've stopped the wildfire, the bad news is the general public thinks, okay, game over. You know, we beat the sucker. We had to stay at home for 3 months, but we've won. Well, we haven't won yet. I think public health would indicate this is not the end of the game. This is the bottom of the first inning. And that's what the healthcare system has to adjust for and come to face as we reopen our society and re-engage. So now you're going to have to trust me that I had some really pretty slides, but I guess we're past those. Let me begin to call on a cadre of experts to talk about what we face or fear we're going to face as we reopen our economy. I'm going to start with Dr. Jed Megan. Dr. Megan is chair of the MSU Department of Psychiatry, is a board certified psychiatrist and specialist in child and adolescent psychiatry, as I recall. Dr. Megan has a variety of other titles, but what I know from working with Dr. Megan is that he is very interested in opening other psychiatric residencies to deal with the shortage of psychiatrists that we're facing in the state. So without further ado, Dr. Jed Megan.
Thank you. Let me preface this by saying that people have said before, prediction is difficult, especially of the future, to futurists. So anything I say, and I think the rest of us say, is somewhat tentative. And let me also say that there are probably two aspects to this. So one is what happens in the immediate opening and what happens in the future once we have a vaccine, if we have a vaccine, which is probably at least a year away. Even when we have that, it's not guaranteed that this thing is going to go away, given the effectiveness of vaccines. And secondly, realize that we live in an entirely irrational healthcare system. Nobody would ever design a healthcare system the way we have one. There's just no way. So given that, in addition to talking clinically, we have to talk about things like reimbursement. It's unavoidable. First, everybody notices we're now in a telehealth world. And telehealth is unlikely to go away totally. That will, of course, depend on what the state and the federal government does in terms of reimbursement. So there's the reimbursement issue. Telehealth is a powerful modality, and it's especially powerful for people who have difficulty getting out of their homes, elderly individuals, and people with disabilities. We would very much like to see it continue, at least for those populations. In addition, if you're in a rural setting, you might be 30 or 40 miles from your nearest mental health provider. It's very useful in those kinds of settings. So that's great. We have this wonderful modality, but on the user end, the patient end of things, they don't always have the bandwidth or even the internet access to be able to use this well. I've had patients sitting in parking lots and talking to me. I've had one patient sitting at the zoo and talking to me because they have bandwidth there. So people are going to access it in different ways. And that's an issue. So one of the things that may come out of this is that it's pretty clear that in terms of healthcare, we need expanded internet access. And you wouldn't necessarily think about that. It's likely we're going to see a mix of inpatient of direct services, that's three-dimensional, patient right in front of you in person, and televideo that's going to continue. You can do that sort of conventionally one-on-one, but think about the power of televideo if you have a team. So if you have somebody with multiple needs, you could just as easily have the psychiatrist, the social worker, the physical therapist, all see that person perhaps by video and make it much more convenient for them and really be able to deliver services in a much more reasonable way. Those could be things coming out of this. Let me also point out that if we have televideo, I can reach out and touch somebody not only in Marquette, Michigan, which is 400 miles away, but just as easily on the West Coast in Los Angeles, say. So one of the other things you might see is that the large health systems, academic health centers, other large health systems might be coming into town. They can just as easily provide services here as anywhere else. So the big providers get bigger and they provide more services. Now, right now, you have to have a license in the state in which you're providing services. But this might also drive state compacts, which are in process, but also something like national licensure. So those are all perhaps unintended consequences of this kind of thing. Another reimbursement issue would be, well, if you're in a narrow network and you want services from a big provider that's come into your state now, maybe that doesn't work so well. So we may have to rethink some of the ways that we provide insurance and reimburse over time. Let me also point out that telepsychiatry is not new. We've been doing telepsychiatry, at least in my department, for the last 10 years to community mental health centers and federally qualified health centers. And in those settings, it's perfectly easy to do because you either have a capitated situation or in the situation of the FQHCs, it's a little different from that. But we've been doing telepsychiatry for a long time, principally to populations that don't have insurance, have Medicaid, that sort of thing. Now, another thing that's important to talk about is probably an increase in unmet mental health needs. Why is that? Well, it looks like in this situation, we've got lots of more people who are having stress and need mental health services. We don't have the providers to do that. So you're probably going to see an increase in people needing services, but an inability to provide those services. Private practice psychiatrists, will private practice survive? Now, all private practitioners are really hurting because the number of in-person visits has gone way down, harder for them to access televideo services. You may see the death of private practice. Rural private practice is in even worse shape. Those people were more marginal to begin with, and those people may be wiped out. As I said before, what replaces that? Well, maybe large systems. Large systems may buy up those people either in state or out of state. And finally, think about niche markets. We've already got boutique practices. It's conceivable that with telehealth, people could go into much more boutique kind of services. Eating disorder services, a variety of other things is a very niche kind of practice. And finally, think about the power of telepsychiatry in terms of providing stepped care. Stepped care being, if you have attention deficit hyperactivity disorder and it's well controlled, I'm a pretty expensive guy to see for that. You could see your family physician, or perhaps you could see a PA or an NP under supervision of a higher level provider, somebody like me. So the ability to provide stepped care, especially with televideo services, is something we ought to be looking at also. I think I'll stop there.
Dr. Megan, thank you. In the interest of time, I'm going to hold questions until the end of the presentations and turn next to our next speaker, Dr. Keith English. Dr. English is a professor and chair of the Department of Pediatrics and Human Development at the College of Human Medicine at MSU. And just by way of background, is also a member of the American Pediatric Society, the Society for Pediatric Research, the Infectious Disease Society of America, and the Pediatric Infectious Disease Society. So Dr. English is well suited to be a COVID-19 speaker. Previously, Dr. Megan talked about the drop in visits to doctors. And I was reading nationally about a 40 to 60% drop in the number of visits to primary care physicians, and the two populations that were the largest percentage of that drop were persons over to 75 years of age and children. So with that as a segue, Dr. English, the floor is yours.
Thank you. Thanks for inviting me. I look forward to being part of this discussion. Could you allow me to share my screen, please? I have updated versions of my slides, so I'd like to share my screen. It won't let me share my screen.
I'm seeing slides on COVID-19 effects on children.
Right, I see those, but those are not the updated ones, and it's not from my screen. But I can talk on those. That's fine. But I was planning to share my screen.
Yeah, here. Let me see if I can manage that. Thank you.
See if that will work. Yeah.
As I've proven to everyone this morning, I am not the technical guru that you want to call on to do this.
Here we go. Can you see those now?
Yes.
Okay, great. So thanks again. And your introductory comments and Dr. Megan's comments are just spot on to what I was going to talk about. And I think I'll help illustrate some of the previous points. So I want to talk a little bit about what the COVID-19 pandemic, the impact that it's had on the health and well-being of children, before I talk a little bit about what the future ought to look like. So there are these direct effects on children. Children get infected. Children can have severe disease. And there is a peculiar and worrisome post-infectious complication I'll talk about in a moment. But really, maybe the only good news of this pandemic so far is that most children who become infected do not become very ill and do fine. Not only that, there's really little evidence that children are the main way that the virus is spread in the community, unlike influenza, where children play the major role. So that's the good news. The bad news is, despite the fact that children have not generally had severe disease, the impact of the viral infection and the pandemic has been tremendous in the terms of indirect effects. And as was mentioned earlier, this has disproportionately affected vulnerable populations of children. African American children, Latino children, children who live in rural areas. And that's because the response to COVID-19 pandemic has resulted in diminished access to care, to education, reduced immunization rates, and challenges for mental and behavioral health, which Dr. Makin's already talked about. So first, the good news. Severe infection by this virus in children appears to be quite rare. And this large experience from New York City, published online just 2 weeks ago, they had a large number of children who were admitted to the hospital with COVID-19 infection in New York City. You can see that most of them, 40 of the 50 children in this report, had fever and respiratory symptoms. A few had only GI symptoms. That's been reported in adults as well. Dropping down to the bottom of the slide, the good news is most children did well. One child died, so one of the 50 children died, but most of the children did not have severe disease. None of the 14 infants, and only one of 8 children who had known immunocompromising positions. But in the middle of the slide, obesity was a risk factor for more severe disease, and we saw that during the H1N1 pandemic, influenza pandemic in 2009. Just another reason why we need more effective strategies to prevent the development of obesity in children. So the good news is severe disease is not common. That's great. However, I'm sure you've all heard news reports about this syndrome, the so-called multi-system inflammatory syndrome in children, MISC, that's associated with COVID-19. This was first recognized in England and in Italy. For some reason that we don't understand, it's not common in Asia where the virus originated. But it's now been reported around the United States, including some 30 cases from our colleagues at Children's Hospital of Michigan in Detroit. We've seen little of this in West or Central Michigan, thank goodness. We don't understand this syndrome. It occurs after someone has already recovered from COVID-19 infection, and they may not have been very sick, in fact, may not have ever had symptoms, and yet they develop this weeks later. It looks a little bit like some other inflammatory syndromes in children. You may have seen it in the news as something like this Kawasaki disease, but this looks like a new syndrome and we don't understand it. Most children who get it do okay, thank goodness. They usually recover. All 30 children at the Children's Hospital of Michigan, the last time I checked, had recovered well. But we don't understand it, and one of the reasons we're worried about it is because it seems to be a late reaction. We worry that a vaccine might trigger an immune reaction that could put you at risk for this. So we need to understand why it happens, what the risk factors are, so we make sure that a vaccine prevents this as well as preventing COVID-19 infection in the first place. So a lot of work's being done about this. So the good news is it hasn't been very bad in terms of the number of children who've been infected. The bad news is the indirects have been great. There's been a tremendous reduction in primary care. There have been complications, as we already mentioned, related to mental and behavioral health. And I don't even have time to talk about the effect of school closing on children and their mental development, et cetera. Let's just talk about one aspect of the indirect impact, and that's reduction in immunization rates. Other than provision of clean water, immunizations have saved more lives from infectious diseases than any other factor. Many more than antibiotics, for example. And yet, one of the problems during the COVID-19 pandemic is we know that fewer children have been getting their vaccines on time. So the CDC has this nice thing on their website that points out you really need to keep those well-child visits, particularly young children, when the immunizations are the most important. That's because they get the most immunizations in, and it's because of the fact that they're at the higher risk for these these vaccine preventable diseases. So if all the children who are supposed to get their vaccine at 2, 4, and 6 months get them a year later, they'll be at risk for severe infectious diseases in the interim, and we don't want that to happen. So we need to do a better job. Here's some national data from the Centers for Disease Control, and you can see that back on January the 20th, when the first U.S. case of COVID-19 infection was reported in Seattle, there already was a fall off in total doses of vaccines being ordered. That's the dark blue line or the solid blue line, and MMR or measles containing doses. That's the dashed blue line. So it was already falling. And then on March 13th, when a national emergency was declared, and shortly after that, we had reduced, we had work at home restrictions in Michigan and other places. You can see that the number of vaccines fell off precipitously after that, so that nationally, we had something like 3 million less doses of vaccines being ordered, which is a good surrogate for how many vaccines are being given. How about in Michigan? Well, in Michigan, we're fortunate to have a great state system and a database, MICR. And so we have data looking at what's going on in our state. And the MMWR CDC published this data about a month ago, showing that unfortunately, those yellow dots, the number of children who are completely up to date on their immunizations had decreased in most children beyond, if you look at 3 months, 5 months, 7 months, 16 months. So that at some ages, for example, here at 7 months, less than 50% of children were totally up to date. Now you can look and say, well, we weren't doing that great even before COVID-19. We had challenges, and that's true. We need to do better in our state. But this made things worse, and the impact has been greater on children who are already at risk not to be getting their routine care or have their immunizations. So I want to end with my last 2 or 3 slides to talk about how can we do better in the future. And, this is going to resonate with what Dr. Megan said and what our introduction today. And that's, it's time to really embrace telehealth and digital health to do a better job of improving the health and well-being of children. And if you only read one thing, I highly recommend this very nice short commentary published in April in the New England Journal of Medicine. I like the title, "The Transition from Reimagining to Recreating Healthcare is Now." The take-home message is pretty simple. We've been talking for a long time about reimagining medicine. It's about time we did something, and I think they're right. We've got to have better telehealth and digital health, and telehealth is part of digital health. Digital health more broadly includes all the things you might do to monitor somebody remotely, whether it's their blood sugar, their blood pressure, their peak flow on their spirometer they have at home that's hooked up to their computer or their phone. We've got to do a better job of taking advantage of these things to monitor the care remotely as well as in person. And as Dr. Megan pointed out, one of the obstacles, but it's only one of them, is we have to have more effective reimbursement. There are a number of reasons why we haven't done a better job of moving forward in telehealth and digital health by now, but I think it's more productive to look at the future and what can we do to change that. So we need telehealth, not just telemedicine. Telemedicine's great, and telemedicine works particularly well in psychiatry, as Dr. Megan pointed out. It works less well in some pediatric specialties, but it can work to some degree in all of them. And you need digital health, and the reason to do this is to add value to that in-person episodic care that we still need. This is not going to replace in-person medicine. It's going to improve it. And while it is important in remote sites, Dr. Megan and I are working together on strategies to try to provide better remote mental and behavioral health support for children in the Upper Peninsula. Is just as important in Lansing or Grand Rapids or Detroit, because you need to be able to have contact with your at-risk patients, both in real time, that's synchronous, but also asynchronous connections. And that's a way to improve your overall health. That's the way it works with my physician here in Grand Rapids. We have a portal. He communicates with me. He's checking on my blood pressure medicine this week and reminding me I'm supposed to increase the dose if my blood pressures are in a certain range. That's the way everybody's health should work. It's better to prevent disease, and it's better to manage chronic disease. So my friends at the Michigan chapter of the American Academy of Pediatrics are all over this. I'm an ex officio member of the board, and I would just point out that just recently, the MAHP was asked by some state legislators to help define what the most important steps we could do would be in the near future to come out of the COVID-19 pandemic and do a great job of taking care of kids. And guess what? Telehealth was the big winner. Telehealth and more broadly digital health. We've made some progress during this COVID-19 time because we've had to, but we have to continue to make these services available, to coordinate this care, and to add that care to the in-person care that we still need to provide. And you know, everything on this slide is not a surprise to anyone. We do need that Wi-Fi access that Dr. Megan talked about. We do need access to primary care and specialists. We do need an entire health team to be involved. This got to be not just the doctor, it's the social worker, it's the nutritionist, et cetera. So, you know, we can do this and we can improve the health and well-being of kids and adults, but we're going to have to maintain this progress that we made during the COVID-19 time. So I'll stop there and be happy to answer questions about this later.
Dr. English, thank you. There seems to be a theme developing here around telehealth. We'll do a segue to our next speaker, Suzette Hirschman. Suzette is Senior Vice President of Operations for the Spectrum Health Medical Group. And her job is to create high-performing medical group operations with an integrated approach across the delivery system. And I'm sure COVID-19 has created a lot of challenges, particularly as we re-engage and hopefully a number of patient visits starts coming back to expected levels, if not surging. Suzette, the floor is yours. Arnold, she's still on mute. Can you control that?
I've got it. No problem. Can you hear me?
Yep.
All right, great. Thank you for the intro. Good morning. Again, I'm Suzette Hirschman, Senior Vice President of the Medical Group Operations for Spectrum Health. And just have to echo again, everything that we are hearing from Dr. Megan and Dr. English around telehealth. It is so important, and the consistent theme that you will hear as I move forward. So my topic this morning is about provider re-engagement, and I'm going to take you through a bit of a journey for what that has been for physician practices and clinic locations as we prepare to surge up for COVID on the hospital side, and then obviously transition back to in-clinic care. So to cover for you this morning, I really want to walk through safety that we have focused on, how we re-engage patients so we could re-engage providers at the end result, virtual again, top of mind for us, and challenges that we experienced along the way with that, and then also some community partnerships that are so important. And I think the slide, Arnold, oh, there we go. So if you can go back to patient safety. Can you hear me, Arnold? Did we lose him, Dennis?
No, he is still with us, but he's on mute. There we go.
Okay, so we can go to slide 3, please. So thank you. Patient safety, obviously, for the industry is top of mind for all of us as we found ourselves going through this prep and also continuing to sustain through so many extra measures that the clinic locations had to put into place. We have been extremely focused on screening for our patients and visitors and team members. Obviously, we had to comply with the EOs as those were being updated, and this was top priority. You will find in clinic locations across the industry that masks are available and required upon entrance, signage that's appropriate, the re-engineering of waiting rooms as we've had to redesign how flow actually will work, and waiting room chairs, etc. And how we have redesigned just even the basics of patient waiting. The days of coming into the waiting room still exist, but also encouraging patients to wait in their vehicles as we've had to migrate to that. Implementing isolation procedures in a clinic location, which is something that you typically do not have in an outpatient environment. And then obviously all of the enhanced cleaning for safety that the industry has had to move through. Next slide, please. And with my topic, with re-engaging providers, we knew we had to re-engage patients first. all of us as patients, as consumers, we have been just inundated with information. On slide 4, please, with information around safety, causing fear, causing uncertainty, causing anxiety. So we at Spectrum, and again, you've seen this across the country, we've had to re-educate patients to let them know that it is safe to come back into the environment, and what we've done to prepare for patients to come back into the environment. That flipping of closing down operations, yet at the same time, the risk around delayed care had to be addressed. So as you look at this slide, you can see on the left, in our clinic locations, we did a significant amount of work around on-site signage, social distancing. You will find the markers of these 6 feet through, on the floor in all of our locations. Again, the signage and seating and how spacing has been incorporated. This is a different experience for patients today, and this will continue in all locations. In the center, you have a picture of a video of one of our physician leaders. The industry has spent time around physician leaders doing personal tours in and out of our locations so a patient can have a real-time view of what it will be like today when you re-enter a healthcare practice location as you journey through a waiting room, registration, what an exam room flow will look like, all of the safety and cleaning that has to continue for our patients and our staff safety. To the right, you will see the industry has had to focus personally on patient and provider relationships, continued messaging that we have taken seriously to make sure that the individual provider and patient relationship is maintained. That is a trusted relationship, and that is the relationship that the patient looks for to receive their information. So we have focused on having that individual communication going from provider to patient. Absolutely see that needing to continue as we move through our COVID experience. And then on the far right, the digital options, making sure that patients know what options that they have. We have reopened in many locations. They can proceed with face-to-face, one-on-one visits. But again, as you've heard this morning, the need for virtual and telehealth, it will continue. And so those individual appointments are also available for virtual. Next slide, please. So this slide is a little upstream of being able to re-engage our providers. What we found in the ramp up for COVID, in preparing for the surge in the hospital setting, we completely re-engineered, again, our physician practice sites. The industry had to do this based on the EOs to obviously stop providing what was named non-essential visits. We transitioned staff to the hospital setting to make sure that critical positions for screening, for visitor education, that all of those roles were filled. We moved our ambulatory physician practice staff into those settings so they could assist with that. The ability to make sure that we had that staff available when it came time to transition back, we had to make sure that the industry is working with the hospital setting to know that we are not leaving those critical positions on the hospital side abandoned, but at the same time had to open back up for our physician practice locations and pull that staff back. This is something that I anticipate that we will have to really be nimble on, flexible on as COVID surges, as it levels out again, it surges again. There's so much unknown, how the industry will have to redesign their day-to-day practice operations to meet the need based on the site of service that need actually exist. And the bottom right on this slide, ensuring that all locations stay informed, just the magnitude of that for health systems. Every location you have, for example, with Spectrum, making sure that we are cascading the EO detail, how we comply, standard work, moving from site to site across thousands of employees and updating that information in a very timely basis. Doing that in collaboration with our hospital leadership, again, has been a challenge for the physician practice side, but we've learned a lot, and we are moving through it. Also with this, on the clinic side of things, we've had a lot to manage with patients. As patients enter facilities, just striking the balance of the comfort level and the presence in which one would present in a site, meaning that you can have a population that felt as though that the country was overreacting. They did not want to comply with the ask of wearing mask and hand sanitizer, the visitor restrictions. And then you had on the other side of that, we have to continue to manage those that are just not comfortable coming back in, and trying to reassure one individual where standing next to them could be someone really debating and challenging, why do I have to wear this mask? So those nuances continue and will continue forward. Next slide, please. Can you advance the next slide, please? Slide 6. Thank you. The executive order impact on slide 6 is a moving amount of information. As we all know, our environment is highly regulated. Multiple bodies with requirements and guidelines based on the EO, but at times we're conflicting information. With everyone with the best of intentions, these separate bodies may come out with different screening protocols for patients, visitors, staff, trying to manage that on a day-to-day basis and make sense of that can be very, very confusing, again, for thousands upon thousands of staff members as they're trying to move through this. One example of that is in our screening. We had an EO that came out that referenced needing daily screening upon entry into a facility, and another EO conflicting that every time a employee entered a facility, meaning they could come in the morning, exit out for lunch, go to break, come back in, that screening practices would have to take place, or another EO said only one time per day from a different body. So just as an example, and pivoting through those as quickly as we could. The industry also has to manage around screening requirements and testing requirements. We also experienced times during this where we had it at our screening sites that the requests were changing within 24-hour periods, and for us to be able as a hospital system to turn a ship that quickly and retrain supplies, PPE, etc., found that those moments are a real challenge, but we've learned and we will be prepared again as we go forward through this. So if we can flip to the next slide, please. All of that to say, to get to provider re-engagement, that was the front end. And for providers to feel comfortable in coming back to the offices, this slide really depicts the path that they were put on. Top left, we immediately closed practices and or consolidated where we had to have some face-to-face visits available. So immediately consolidated. We redeployed providers into the hospital setting, whether they were redeployed or ready to be redeployed. We had over 200 primary care providers just in our system alone that were credentialed, trained, and ready to move into the hospital setting for surge needs. Immediately moved to virtual at the same time. Again, saw locally and across the state and nationally how so many systems flipped and were able to provide this service for care. Then moved into reopening practices at the same time that providers had to be continuously educated on COVID, and that is still going on today on a daily basis as the science and the learnings advance. And then we moved forward to, at the same time, trying to bring providers back into the offices. We all know what was happening nationally around compensation, providers possibly being let go from their positions. There was a lot of anxiety, and that anxiety continues today around provider staffing and their compensation. We were fortunate here that we had very minimal impact there on the provider side, but also very, very concerned about staff and what will the future of our operations look like, and how will we redesign this going forward. I think we're changed forever in this scenario. Next slide. So slide 8, please. And I'll move quickly through these. On slide 8, this gives you a timeline of what this has looked like for the industry. Quickly here, on March 16th, obviously stopped our daily operations, redeployed providers. March 20th, we went live virtually with primary care visits, all virtual. Specialty March 27th. And then hit our high for virtual on April 30th. So you can see how the patient capacity and the need immediately from March 16th to April 30th, having a daily encounter visit of over 2,000 virtual visits per day. And then flipping to May 4th to reopening, and then May 29th moving back to some normal sense of practice operations. So as an industry, this is what we've experienced, but the learnings from this will enable us to do this over and over again as we may have to. Next slide. The shift to virtual for us has been a focus on primary care with consults and follow-ups, specialty visits, and then our low acuity on demand. And again, this is something that we've seen across the country, and where the focus has been. Is this here to stay? Absolutely. I do not anticipate, nor does the industry anticipate, as we've heard this morning, that the need for telehealth and virtual services will go away. The demand is only going up. But we have learned in a tremendous amount of reading and my colleagues across the country that first experience with telehealth and virtual is so critical, as we're already seeing a sharp decrease in telehealth visits and virtual here locally. We do not anticipate that to be the curve ongoing, but as we've opened back up, because the initial experience was shifting to the technology and the challenges that we've heard this morning around bandwidth, around devices, automatic links so patients can download immediately or link immediately to video platforms. Those are all challenging and something we all had to learn and stand up quickly. So that experience, I think, has probably put us in a position to need to recover on that experience for many, many patients. Next slide. This just depicts the high and then the drop that we are seeing right now as we ramp back up our virtual. Next slide. And then wanted to speak a moment about locally here. All of us know that within the state and for West Michigan that our employers were just significant partners with us, but they also struggled and needed to rely on us to help them reopen for their sites and safety. So we immediately went into action, as many health systems have across the country, to provide employer guides, screening guidelines, emergency contact numbers, web detail for our employers to be able to look to us for a partner so we can keep the curve flattened and continue to assist with them. Next slide. The employer guide on the left is something that we have available for all employers, and this is free in addition to consultative services to assist their employees to come back. Next slide. And this is focused on how an employer can get prepared, how they can set up their sites, their offices, their manufacturing floors for social distancing, how to understand and create protocols for symptomatic employees, and just overall education and videos for staff as they come back to learn about COVID and how to be safe in the working environment. Next slide. So that's the end of my presentation. Wanted to give you, again, a quick overview of what clinic operations look like now and how we've had to re-engage providers, but also making sure that the anxiety of the provider is recognized and we've taken care of them and have provided resources not only for patients and the providers to come back into the workplace from a very, very challenging 90-day period. Thank you.
Thank you, Suzette. A quick question, if I could. PPE, do we have adequate supplies of PPE for the industry? I was asking, not Spectrum.
Mm-hmm. For the industry, and Chad can speak to this also when he talks here shortly, but yes, we are seeing that we do have adequate supplies now. There are pockets across the country where there are still struggles though. And as I think the ambulatory physician provider side has really had to wait and make sure the hospital settings had that PPE and then transition the PPE to the reopening of our physician practices. But overall, we are seeing a much improved situation on PPE, but there are locations that are still struggling across the country.
Thank you, Suzette. I apologize if I took some of Chad's thunder, but
no problem.
Moving on, as we indicated earlier, the 90-day stay-at-home order that we have just gone through unbalanced not only healthcare delivery, but also healthcare finance. And to talk about re-engaging from the healthcare finance standpoint, we have Dominic Pallone. Dominic is Executive Director for the Michigan Association of Health Plans, and as Executive Director for 13 different health plans across the state, it really has a unique view of what we're going to be facing. So Dominic, I'll turn the floor over to you.
Thanks, Denny. I'm just waiting for the video to be unmuted here, but.
Well, I can hear you, Dominic. So.
Okay, great. I'll get going then. So thank you very much again. Thank you for allowing me to be a part of this. I'm Dominic Pallone. I'm the Executive Director for the Michigan Association of Health Plans. And Arnold will help drive my slide deck here. If you want to go to the next slide here, it's just a brief overview of who we are. I won't spend too much time on these first few slides, as I think most of the folks on this Zoom call have worked with our association before or myself before. Arnold, if you want to go to slide 3. There we go. Perfect. Just an overview of our members. We have had some consolidation of membership here. So some of the plans that you see listed have acquired other plans that you see listed, but just to give you an overview of all of our members. And next slide, please. And then our vision, obviously, the vision of our association here is to really focuses on improving value, affordability, and choice and competition within all of the marketplaces. So, you know, speaking from the industry's perspective here, from the payer's perspective here today, just wanted to give you a little bit of background on who we are. And then as we move into the next slide, please. What I really want to talk about today briefly, and then happy to answer questions as we wrap up. Really want to focus on some of the effects on the health insurance industry, potential market shifts that I'll discuss here in a moment, and then those effects on access to coverage for Michigan citizens and on effects to employers and to healthcare providers as downstream effects caused by those market shifts. So start here with just a mention of a couple of national estimates that have been produced. This first one on this slide is from Robert Wood Johnson Foundation, May 4th report that they produced. Had a number of estimates in there. The middle range was estimating about a 20% national unemployment rate change. And then they had numbers specific to Michigan. I'll mention some of those here in a second. So in Michigan, as most of you know, our current unemployment rate is above 20% right now. However, the national unemployment rate, I think, is slightly below 20% right now. So, you know, for the purposes of our calculations and some of the slides that you'll see here in a moment, we've kind of taken that middle road approach, estimating roughly 20% unemployment rate in Michigan. Nationally, what the expectations are, according to this national study, is that Medicaid is expected to grow by 11.8 million enrollees. That's a tremendous growth, obviously, across the nation. Some of that growth will be greater in states like Michigan that has an expansion program, the Healthy Michigan program, rather than states that have not yet expanded their Medicaid program. The uninsured is expected to grow nationally. The estimates here by Robert Wood Johnson is 7.3 million nationally in the uninsured. And then the individual market is expected to grow by 6.2 million people nationally. That's the marketplace that people often turn to as their employer might start to cut employee-sponsored coverage, or they might lose their employer-sponsored coverage because of a loss of employment. Oftentimes, folks will seek coverage through the individual market. That's different than COBRA coverage. That's different than continuing your employer-based coverage. In Michigan, some of the specific estimates by Robert Wood Johnson were an estimated loss of ESI. You'll see that ESI designation for employer-sponsored insurance of just under 750,000 people in Michigan. That's a tremendous number, obviously. It means an estimation here of a gain ultimately in Medicaid of just over 400,000 people in Michigan, a gain in the individual market of 163,000 people roughly, and obviously another gain here in the number of uninsured by 155,000. Next slide, please. Another national study, the Health Management Associates put out an estimate. It again had a range here of effects, estimating really focused on Medicaid enrollment, but also took a look at the loss of employer-sponsored insurance, the individual market gains, and the uninsured gains. Michigan numbers here, again, a little different than the other national estimates that were out there. This one was done about a month prior to the other one coming out. I know constantly some of the national organizations are revising their estimates as more information becomes available. But again, some startling numbers here that I think everybody should be aware of. A tremendous estimation in the loss of employer-sponsored coverage, tremendous estimation in the growth of our Medicaid coverage, and increases in the individual market, and again, tremendous increases in the uninsured. Next slide, please. So these market shifts that I just explained some of the national estimates on, we're tracking them to see how fast those changes occur. That will have a major impact here on both providers and employers and policymakers in our state. But I wanted to give you a little bit of an overview here as the impact, the financial impact, as to what that may mean to providers across the state of Michigan. So we've made some assumptions here, and I want to be clear of our assumptions. These are our best guesses. These are back of the envelope assumptions here, and I try to explain a little bit of that on this slide here. As we see folks move from employer-sponsored to other coverage, it means the reimbursement rates are going to differ than the reimbursement rates when they were receiving that same level of care, that same service under the employer-sponsored benefit. Based on several national studies, it's estimated that commercial reimbursement rates for hospital services, that's inpatient and outpatient combined, are on average about 199% of Medicare levels. And then again, according to national estimates and a national review by Kaiser Family Foundation of Michigan's fee-for-service fee schedule in Medicaid, compared to Medicare reimbursements for the same services, The uplifted payment amounts, we have a number of uplifted payment programs, are estimated to be approximately 71% of Medicare. So just to level set there, as folks move from employer-sponsored coverage to Medicaid, for example, you're going to see this tremendous shift in reimbursement amounts down in reimbursement levels to providers. Next slide, please. This, again, is Kaiser Family Foundation giving a little bit more of the detail here, all hospital services versus inpatient, outpatient physician services. You see, you get some different inputs there. I did want to disclose, obviously, my estimations here are not exact, but give you a little bit of background. And next slide, please. And now, I was told that I'd be able to avoid math as I got into this career, and I found that I can't avoid math, so I'm not going to let any of you avoid math. So I want to walk you through a very quick hypothetical math quiz here. So get your pencils out. I won't grade you on this, but again, going through some of the estimations that I just provided, that I want to tell you some more inputs here. The average premium for Michigan, that's employer plus employee cost for an employer-sponsored insurance premium, is in 2018 was $6,322. If you were to estimate that roughly 85% of that premium dollar is then being spent on medical care, on medical claims, that then means about $5,373 per person being spent on medical claims for those that are employed and have insurance through their employer. With that loss of employment, as I just referenced those other levels there, some of those people will go to the individual market, which is still going to pay commercial rates. It's still a commercial product. The remaining population, as I referenced, will either fall into Medicaid, or they're likely to fall off of coverage entirely. For those that fall off of coverage entirely, that's a complete loss in reimbursement. For those that fall into Medicaid, they'll be reimbursed at a fraction of what the commercial reimbursement levels were for the same service being provided. At the end here, that big bold number is meant to be a big scary number, just under $3 billion in potential lost revenue. That is just the simple back of the envelope math dealing with market shifts that we and that national experts anticipate will occur in Michigan. That's providing the same amount of services that were provided pre-COVID, being eventually ramped up post-COVID. Obviously, there's a lot of other inputs here, and this is not an exact estimation by any stretch. And some of the previous speakers spoke towards changes in utilization, changes in the dynamic of how services are being delivered. I can tell you, certainly we're seeing pent-up demand start to be relieved as we move forward. That will affect some of this reimbursement as well to providers. Next slide, please. Just an overview here of pre-COVID, where we were in market breakdown, and this gets into the various levels within the employer sponsor insurance. Self-insured is the ASO bucket there that you see, and then post-insured under some of those estimations. Next slide. And then I want to leave you with some policy considerations here. So a lot of these considerations are being discussed at the national level, obviously. But critical is what will happen and what policymakers can do as we're trying to re-engage our economy. The biggest thing that we see as insurers is trying to maintain access to employer-sponsored healthcare. That's going to be important, as I just illustrated, to the provider community and making sure that they're adequately reimbursed for their services. And it's obviously important for the individual to make sure that they have continued access to high quality care. And it's important to the employer to make sure that they have a healthy workforce that can trust it. Our industry, joined with a number of others here, obviously AHIP, our national organization, and then the Chamber of Commerce, the AMA at the national level, AHA, the American Hospital Association at the national level, have been fighting for congressional efforts to help employers and employees, and I'll say most notably not insurance companies. And I've itemized about 5 different policy considerations there for folks to consider. Again, most of those are applicable at the national level, but I wanted to make sure that everyone here on today's meeting was aware of what was going on and the effects that this market shift will have in reimbursement and the financing of healthcare as our system as a whole. And with that, Denny, I'll turn it back over to you. Thank you for allowing me to present today.
Dominic, thank you. Those are sobering numbers. I wish you'd stay away from math. You get scary when you do that.
I wish I could too.
Dominic, I thank you. Moving on to our next speaker, Mr. Chad Tuttle. Chad is the president of post-acute care for Spectrum Healthcare System and the interim senior vice president for hospital operations. So in that respect, Chad has oversight for all the hospitals and continuing care operations in 13 counties in and around Grand Rapids. I would also note that Chad is a licensed nursing home administrator and does work in that area, and that will be a topic for later discussion. Chad, the floor is yours.
Great, thank you, Dennis. So some of my slides may look familiar to what Suzette shared earlier. I will go through that briefly, but appreciate the opportunity to speak to the impact on hospitals. As we are aware, since this started for Spectrum, roughly the beginning of March, we opened a command center, and that command center has remained opened through the duration of the COVID pandemic. This is similar to many other health systems, and our health systems are closely linked in close communication and coordination with each other. For Spectrum, that allows us to maintain 24/7 oversight and coordination across 14 hospitals. Through that process, we can provide ongoing monitoring of our patient situation, our testing, supplies, capacity, staffing. We have work groups stood up under this structure to ensure that we are always ready to meet the needs of the community and that we can surge our resources to the most appropriate places and settings. Related to the earlier question, it also allows us to monitor our PPE supply utilization. We monitor that down to the usage level on a daily basis. While our current supplies are adequate, that is an ongoing concern really for healthcare in general. Our usage rates have increased more than 7-fold across our key PPE elements: masks, gloves, gowns, face shields. And so that is something that on an ongoing basis, while we have adequate supplies for the moment, we know that as the economy reopens and restarts, there will be additional consumption and utilization of PPE, and we're very mindful of that. We believe suppliers have ramped up. We know locally we've seen a lot of manufacturers get into the business, and that has been welcomed. We have worked with a lot of new partners in terms of acquisition of PPE. Our command structure also gives us real-time data to make decisions, inform our plans, and course correct. So that is a structure that we're accustomed to in healthcare, and is not specific to Spectrum, but really across all hospitals. And then the theme is safety. And so I'm going to talk to you in terms of how we go about preparing ourselves to move forward in a COVID world. Starting with our team members. So since early March, all of our team members have been subjected to daily screening, which can include temperature checks, symptom screening. We have that be a virtual screening, but if somebody screens out as having a concern, we have a provider call them virtually immediately and connect with them to determine if we should send them for testing. We are also very focused on PPE. We've enhanced our PPE guidelines by role so that we can ensure whether it is the person bringing food to the floor, the person cleaning the floors, or the nurse at the bedside, that we have appropriate PPE training and PPE supplies for all of those staff. We also have something you'll see in that PPE, something called a hot zone boss. That's a new term for us, but it is an individual whose sole job in certain areas of the facility is to ensure appropriate utilization of PPE is happening. We have hot zone bosses on all of our COVID units where patients with COVID-19 are cohorted. And so we have staff who are basically there to ensure PPE is donned and doffed appropriately on a consistent basis. We also, in terms of labor pool preparations, we have cross-trained staff to make sure that staff are available to float to the areas where those most critical needs are. We're very mindful of staff safety and limiting exposure, so we've had to make adjustments in areas like break rooms and shuttles from parking lots. We've offered extensive remote work options where if people don't need to be on site, we make sure that they're not on site. We've had to stand up additional respite areas. Our break rooms, frankly, aren't large enough to accommodate social distancing, so we have converted other areas of the hospital into respite areas that can provide social distancing for staff, and then made cafeteria modifications. An interesting fact that people may be aware of is in West Michigan, our hospital cafeteria is the busiest restaurant in all of West Michigan. I suspect you would find that to be the case in many areas of the state as well with the large hospitals. And so there's had to be modifications to cafeterias. And then offering help chains for staff, that if there's any concerns, that they have the ability to escalate those concerns quickly. An area of note, when we talk about visitors, families are not always friendly to our policies around masking and our visitor policies. And so we've had to offer a lot of support for our staff to address visitors or patients who may have concerns that they want to raise. In terms of our physical environment, we have signage beginning in our parking areas. We have controlled all entries to all of our facilities. We have 100% masking and hand sanitizing at all entries. We have very limited visitor policies. More frequent cleaning of high touch areas. Hospitals have always been very safe, very clean environments, but we have even stepped up our sanitizing protocols additionally. We've removed furniture from many areas to ensure social distancing, as well as to eliminate high touch opportunities. We've also offered visitors and family members the opportunity to wait outside for procedures and receive calls. And then from a food service perspective, to offer room service dining options in addition to the limited options in our cafeterias. For patients, we recognize that COVID-19 is here, and so we just need to account for that fact. So in terms of COVID-19 positive patients, we have severe isolation protocols in place. We have very much restricted visitors. We cohort those patients onto particular units. As I mentioned previously, we have the hot zone bosses, and then we do ongoing contact tracing. And I'm very, very proud to say that with these measures, we have hundreds and hundreds and hundreds of staff caring for patients who are COVID-19 positive. But because of good infection prevention protocols and good utilization of PPE, we have successfully avoided those staff from contracting COVID-19. So our policies, our procedures, our PPE utilization works. In terms of patients who are not COVID-19 positive, well, that's really our question always, is we sort of assume everybody could be an asymptomatic carrier. So we have plenty of testing options, whether that's in ED tents, drive-through testing options. We now do serology testing, and most recently have added the NERES testing. A lot of people are familiar with a nasopharyngeal, which is that the test that we've all seen that looks like you're nearly lobotomizing somebody. But the NERES testing is a nasal swab test that is CDC approved now, and we are utilizing that test in our ambulatory settings as well as for large cohorts of individuals, employers, and others. In terms of protecting patients and team members, we do require 100% pre-procedure testing. So if we know somebody's going to be coming to the hospital for a procedure, we test them prior to their arrival, typically within 48 hours of them arriving. But we still screen everybody at all intake points and require 100% masking and sanitizing of those individuals. In terms of visitors, that has been a very active dialogue in Michigan. We know that there have been multiple executive orders providing direction. Hospitals have been very keen to those, as well as just determining what is the safest process for each of our settings to take. And so we do have to account for differences in settings, adult versus pediatric settings, inpatient settings versus outpatient settings. Each of those require their own nuances in terms of visitor policies, but in general, our visitor policies do limit visitors in number of visitors, the frequency that they are allowed to visit, in the duration of those visits. So even in those areas we do allow visitors, we try to not allow everybody to have all of their visitors at the same time. So that has been an administrative process that our teams have had to learn quickly, but have adapted very well to as that changes on an ongoing basis. Visitors as well are screened and trained how to don and doff PPE, particularly when we have visitors who are coming for patients who may be at end of life. We do, in many cases, we will fully gown those visitors. We'll put face shields on them, mask on them. And so we have to train them how to don that and how to doff that in safe ways for them, but in ways that also allow us to have humane visitor policies to ensure that we can absolutely ensure that our patients receive the care and the support that they need during this time. Suzette already showed the We're Ready For You campaign, so I won't spend much time on this, but what I do want to point out is, in terms of our hospital settings, We're Ready For You is really intended to ensure our patients understand we are safe and we're ready for you. Our greatest concern has been that during this time, the patients who should seek acute treatment, we have seen many patients delay that care. We have seen people come in who have had strokes 48 or 72 hours previous, heart attacks 2 to 3 days previous. And in many cases, we are seeing people who, when they arrive, are very, very sick, very much in need of treatment, and very much have delayed appropriate care. And so we are actively educating our communities. I'll point out this We're Ready For You campaign. We are actually providing in 7 different languages. We are promoting in our communities in languages that are most appropriate in our communities and our patient cohorts, to make sure that we can get that message out that we are safe and ready for patients. In terms of the way forward, we know testing is a strong part of our future. We say testing, testing, testing. We will be doing testing well beyond the time frame where we have a vaccine. And so testing is just a part of our new normal. We see it our role to provide ongoing community education as well as team member communication. We want to make sure that people are informed of our status, as are most hospitals providing dashboards to the community. I can tell you very positively this morning, our hospital has the lowest volumes of COVID-19 patients that we have had in over 2 months. We have been on a steady downward decline for 20 days now, and that trend is continuing very positively. In terms of clinical care recovery, we are also focused on ensuring that we are open for business and making sure that those people who have perhaps put off or delayed care are coming in. Currently, in most areas, we're at about 80% of our pre-COVID volumes, which is really the reality, as Dominic shared. Our new reality that we're trying to adapt to is an environment that generally has higher costs and reduced revenue. We've already seen the impact of this in Michigan in terms of many health systems have already had to go through some position eliminations in an attempt to lower overall costs. We expect that as we determine what volume is coming back and what the new payer situation is, that hospitals will continue to have to be very nimble and agile in adapting to this new reality and finding ways to lower our overall cost structure. So with that, Dennis, I will hand it back to you. Dennis, you're muted right now. You're muted right now.
How's that?
Perfect.
Question about contact tracing. You mentioned it. It was unclear to me whether Spectrum was working with local health departments or Spectrum was doing their own contact tracing.
Yeah, so contact tracing in West Michigan, particularly in Kent County, is being led by the health department, but we have supplemented and augmented that with our teams, and we have trained hundreds of our staff to support contact tracing measures.
I see. Thank you, Chad. Moving on to our next speaker, Mr. Dennis Litos, who's the interim CEO for the Michigan Primary Care Association. Dennis has, I won't even embarrass Dennis by saying how many years, but multiple years of experience, both as a healthcare CEO for hospitals and an insurance company CEO. Dennis's current position with the Michigan Primary Care Association allows him to represent the community health centers and who serve some of Michigan's most vulnerable populations. So, Dennis, the floor is yours.
Thanks, Dennis. And can you hear me okay?
Yes.
All right, great. So we'll go ahead and get started here. Well, first of all, I just want to thank you for an opportunity to talk about community health centers and the impact COVID-19 has had on them. I'll do a brief overview of community health centers. Won't spend too much time on that. I'll talk more about the financial impact of COVID-19 on health centers, the impact telehealth has had on mitigating that financial impact and where it plays going forward. Talk about some issues regarding return to the office for our health centers and getting them reopened. And then a little bit on health policy that can positively impact the situation. So can we move to the next slide, please? All right, so community health centers are consumer-driven, patient-centered local healthcare organizations that provide care to people who live in areas of high need. I think most of you understand that. And the services that they provide are tailored to fit the needs of those specific communities. And our mission is pretty straightforward, and that is to provide high quality, affordable, and comprehensive medical services to everyone that we serve, regardless of who they are, where they come from, their ability to pay. So you'll find us, of course, in the urban areas and rural communities where it's difficult to get primary care services provided to patients with those kind of needs. So our total population of patients, a little bit over 700,000 that we serve. But what's key here is the majority, over 635,000, live in poverty. Almost 49,000 patients are homeless. Over 214,000 are children we're serving. A little over 13,000 agricultural workers, and almost 230,000 that we identify as racial or ethnic minorities, and about 15,000 veterans. Next slide, please. All right, so you can see that we provide a complete blend of services. So we do provide integrated care to our patients, medical services, dental care services, behavioral health services, substance use services, vision services, and enabling services such as transportation, translation services, and health education and support to all of our health centers. Next slide, please. All right, so taking a look at how we do impact the healthcare economy, one of the things that community health centers are known for because of their integrated care model is the amount of money that we save on a national basis from the healthcare system, and that's about $24 billion a year. And that's really driven off a lower cost per day per patient in terms of what health centers provide compared to all physician settings. Next slide, please. So this will give you a perspective on the impact of COVID-19 across the nation. So we've had almost 1,800 health center sites temporarily closed due to COVID-19. So completely closed. I think we heard a little bit earlier a discussion about consolidation of sites. So health centers have been through that same kind of model. 8% of health center staff are unable to work due to having COVID-19 nationally. And then health center visits are down to 63% of normal rates. Next slide, please. So let's talk about our health centers here in Michigan. So 74 community health center sites are currently closed here in Michigan due to loss of patients from the COVID-19 crisis. This represents 21% of all community health center sites here in Michigan. And even after federal funding support from the CARES Act and Stimulus 3.0, the community health centers were showing an $84 million loss of revenue there at the end of April. And that, of course, is because of drop in patient volume. Now, the CARES Act, we weren't as fortunate as other healthcare organizations in the amount of money we received. And to put that in perspective, a very large health center, one of our large health centers is Cherry Health in Grand Rapids area, and Great Lakes Bay, two very large health centers, both have, over 25 sites throughout their regions. The amount of money they received was about $1.4 million at Cherry Health. And if you put that in perspective, that doesn't get them really through 1.5 payrolls. So the amount of money that was received really didn't help fill the void, and that's the reason for these losses still continuing. Approximately 33% of our health centers have 30 days less or less cash on hand, and the majority of health centers have less than 60 days. So health centers are not, financially well off to begin with, and COVID-19 obviously has had a major impact. So next slide, please. So one fortunate thing is community health centers do receive approximately 25% of their operating costs from HRSA's Section 330 grant funding. The remainder of the funding does, though, come from patient visits. Community health centers take care of the low income, as we talked about before, so don't need to be redundant, but most of the patients that they care for have Medicaid, Healthy Michigan, Medicare, or uninsured. And of course, with the expansion and uninsured that we expect, that will place more burden on community health centers. Community health centers expect to see more uninsured, as we talked about, just because of the high unemployment rates. And obviously, that'll be even a tougher challenge for health centers in serving that population in the future due to their current financial condition. Next slide, please. So we're no different than any other organization. You can see here, these are Michigan numbers. So, we've reduced hours in health centers by 64% on the average. Voluntary paid leave, about 55% on voluntary paid leave, about 44% on voluntary unpaid leave. Layoffs, about 58% of our health centers reporting, and other issues for not having staff. Next slide, please. I thought it'd be interesting just to take a look here, looking at the left side of the slide. This is a perspective from 2018 Bureau of Primary Healthcare, the UDS data, showing telehealth services across the country. Of course, in 2018, we weren't providing those here in Michigan, other than maybe on the commercial insurance side, but certainly not Medicaid not being reimbursed for it. We were in a program, we had a grant and had 6 of our health centers getting some funding for doing telehealth services for mental health patients in partnership with U of M, but that was the limit of what we were doing at that time. So if you look across the country, there was a lot more activity happening because it wasn't happening here in Michigan. But the primary care side of things amounted to about 30% of the telehealth visits, and mental health was the largest, averaging around 65% overall. Next slide, please. So as we think about that slide and think about telehealth services here in Michigan, telehealth services obviously have jumped up to a large degree for our health centers, and we're certainly grateful that MDHHS put in place the emergency telehealth policy, and that happened within a few weeks of the COVID shutdown. And health centers in Michigan moved then from about 80% drop in patient volume early in the crisis, those first 2 or 3 weeks. And once we knew telehealth was going to be approved, we moved quickly into telehealth services. And currently, we're at about a 35% drop in patient volume today as a result of having telehealth services, which we appreciate. Health centers are currently operating now at about 65% of their previous patient volume. And with that, 70% of those visits are being done through telehealth. So it's a large number of visits happening through telehealth. We still have some patients coming into our health centers. Those are your sicker patients with chronic diseases that need more face-to-face encounter with our physicians. We talked earlier about patient anxiety and the convenience of telehealth. That's made it easier for patients not having to come to our clinics for treatment. And certainly that's going to turn to be I think the visit of choice for many patients in the future. We talked about that earlier as well. And of course, that depends upon diagnosis. But considering the apprehension we have about a reboot in what's happening in COVID-19, we've seen the bump in other states that started to open up. We assume that we're going to see the same thing here and be operating in this environment for at least another 12 to 18 months prior to having a vaccine in place. A couple of things on the telehealth side that are really key, and we appreciate our legislature here in Michigan. They passed House bills. The Senate passed the House bills 54, 15, and 16 that ensured telemedicine services would be covered under the Medicaid and Healthy Michigan programs. And on the U.S. Senate side, our Senator Peters here in Michigan has been one of the proponents of healthcare broadband expansion during COVID-19 Act. I think Dr. Megan talked about that earlier. It's really important that we get broadband services to our rural areas. We were very fortunate when telehealth was approved in Michigan. We were allowed to get paid for a visit if it was simply voice to voice and not having anyone either on a tablet or on a cell phone that you could see, but voice to voice communication. And that was really helpful for our rural areas. And I think will be something we need to consider also in the long-term future here. The U.S. House and their bill improving telehealth for the underserved communities really allows for Medicare patients for community health centers and our clinics to get an equal payment to an in-person visit, which is also very helpful to our health centers and rural clinics because obviously we're going to get revenue for those services now and going forward, not just during the emergency. Next slide, please. Let's move one more slide, please. The challenges to reopening. Permanent loss of providers and staff who have been laid off or furloughed due to COVID-19. In some cases, we have our employees who are immunocompromised, and we've had actually some physicians leave practice, but certainly our health centers have lost physicians, nurse practitioners, physician assistants, during this time because everyone needs to be employed, and they have not been in the position to continue, for the most part, employees without having them fully laid off or at least using their paid leave. Additional operating costs to reopen, such as new provider recruitment, that's going to occur. Infection control processes, all the things that were talked about earlier by other speakers. But one of the things that's really critical is to understand that the actual cost of operating a primary care office and the size of the offices that our community health centers have can be very expensive. And we all know that there's more accessibility to PPE, but the cost of PPE is outrageous, as we all know. And the cost of telehealth equipment, any kind of medical equipment, all costs have gone up dramatically. So as we retrofit our facilities and changes that need to be made as we reopen, that's obviously a capital cost to all of our health centers. Talked about earlier, patient, employee, and provider anxiety, hampering return to in-person visits. And we're worried about that. So one of the things that we are doing that is interesting is we're partnering currently with two of the statewide Medicaid plans. And with one of them, we're just concluding a contract for community health workers to be funded for our health centers at various sites to help provide on the ground, in the health center, and outside of the health center activity, to also encourage and bring patients back and have that outreach communication that's going to be necessary to provide the kind of comfort and explain what's happening within our health centers to bring patients back. The one challenge that our health centers do have because of the financial challenges that have been experienced is the lack of financial resources to get community health centers back on their feet again, as they're trying to get this back under control and make the financial investment necessary. So they're looking for additional funds to make that occur. On the next two slides, we can go through quickly, but it just shows you that simple things like automatic fixtures in your patient exam rooms as well as in your restrooms. Next slide, please. And then what we do for alternate decontamination in the air systems within our health centers. They can go from very expensive on a centralized system to a little less expensive. But those are just two areas for examples that our health centers have to spend money on that they were not spending money on before. Next slide, please. So addressing the financial challenges of reopening. And the CARES Act, a Stimulus 4 package that we expect to see in one way, shape, or form. Of course, primary on the agenda is getting funding for states and municipalities and helping to refill the gaps and lost revenue that states have had from the tax impact of COVID-19. We also were successful in getting, at least into the House bill, the $7.6 billion to assist community health centers to recover from COVID-19 and to reopen and grow services. And so those are really important. The focus of that funding would be to reopen and grow services so that as we have more uninsured and more folks that are going to be on Medicaid or Healthy Michigan, we have the opportunity to step up and provide services to those patients. So we hope that happens. We weren't successful in Stimulus 3 in getting the amount of money that our National Association and our community health centers across the nation were asking for. But we hope that this happens in the next go around here. And then on May 14th, this is an interesting sort of change of events. CMS came out with a bulletin.
Dennis, I'm going to have to ask you to economize on your time. We're running into a time problem.
Yep, I'll be just about 2 minutes here. The May 14th bulletin, I'll touch on the next slide here quickly. But slow and steady reopening of community health centers is a way to grow revenue as they have the opportunity to do so and to improve the financial stability of the health centers. So now I'll move to the next slide. One back, please. One back before that, sorry. All right, so this bulletin that came out from CMS really helped to direct states on how they can work with managed care plans to temporarily enhance provider payments under the contract in order to sustain and retain Medicaid providers. That's one of the requirements, of course, of the Medicaid program, is to ensure you can retain Medicaid providers. So we did work with a coalition of different associations, the Michigan Association of Health Plans, the MPCA, the Michigan Osteopathic Association, the Michigan Center for Rural Health, the Michigan Academy of Family Physicians, the Michigan chapter of the American Academy of Pediatricians here in Michigan. And with that, we did provide a proposal to MDHHS, which we're hoping they'll react to positively. This is happening in other states currently, so we hope that happens for us as well. And I'm going to close there because I think I probably have run a little bit over time. Thank you.
Dennis, thank you. I appreciate your comments, and I'm sorry to rush the issue, but we have questions from legislators. I really want to have time to get to those. So I will ask all of our speakers that are coming up that are on deck to be concise in their comments as well. Our next speaker is Constance Conklin, a licensed social worker. Constance is the executive director for the Livingston County Community Mental Health. In the briefest of fashion, Connie has a substantial background in this area and has worked for the state of Michigan in the Department of Community Health or Mental Health Services for Children and Families. So with that brief introduction, Connie, the floor is yours.
Okay. I am going to share my screen. All right, maybe. All right, it's not showing this. I'm just going to go ahead and speak, and then I'm going to share my PowerPoint because I'm going to be kind of trying to condense this as much as possible for the sake of time. So I think I want to start with some lessons learned around COVID and the whole experience from a community mental health standpoint. We have remained open, but been doing a lot of telehealth as well, but all of our sites have been open. And I think some of the things that we really have seen is, you know, that there's a high expectation around our public system to be able to respond in kind of a time of crisis. And we really saw an increase. Again, when it first started, it was kind of a lull. I don't think anyone knew kind of what to do. And then once school started with the Zoom calls, we were getting a lot of contacts from teachers, primary care doctors, caregivers, protective services, and law enforcement. I think some of that has to do with when people are living together in the close quarters and they can't go anywhere, they recognize things about each other that maybe they didn't recognize before with regard to either substance use or behavior. And so I think some of that resulted in an uptick in a lot of our crisis calls, not from our primary consumers, but from the community because they knew we were open. So they were contacting us. The other thing is, we're not an obvious kind of essential worksite healthcare center. So we had to do a lot of hunting and gathering for PPE. And so I think that was something that was a big challenge, because we had nurses that needed to go out and do injections, and they either went to a home or people were coming in and they were doing injections in cars. And so there was a lot of creativity with regard to PPE that we did. So, and we worked with our health department, emergency management, and the state as well on that. But I think we really found that we were basically running kind of a new model, a new agency around the telehealth and some of the safety measures that we needed to incorporate. I think our direct care workers that were working in our group homes, our specialized residential, and working in people's families' homes, and kids, as well as adults, that they were the real heroes in the system. I mean, they were providing 24/7 care to some of our folks with intellectual and developmental disabilities, that without them, there would have been a bigger crisis in some of our facilities. And we did have some positive cases in those facilities. So dealing with the quarantine and some of that was, I think, challenging. One of the big things that happened as a result is, we partnered with the state agency in kind of a different way than we had before. It was kind of rebuilding our partnership versus a compliance-driven system, which was that was necessary and nice. So I think the ability to be responsive and to say this is what we need and have the State Department really be responsive to that was refreshing and nice. We saw a significant increase in substance use. And I think some of that had to do with, part of recovery is you have traditions, you have rituals, you have kind of a structure of how you navigate recovery. And with a lot of our folks, that structure was the rug was pulled out from them. And so being able to kind of create new support, and in our county, we have a Stepping Stones Engagement Center, which is open from 5 o'clock at night until 9 o'clock in the morning, and then it's 24 hours on the weekends, is a recovery center. So anybody, it doesn't matter what insurance, anybody can come there, and we provide support around substance abuse recovery, and then try to navigate getting them into services that they need. I think the other big thing is around collaboration and communication across our county. It's one of the things I'm thankful for is we try to figure things out together, and as well as I think our region and the state. Kind of what we're preparing for is, children are resilient, but you can't take away their structure and routine for long without creating some kind of imbalance. And I think not just for the children, but for the whole family and parents, and trying to navigate that. And so I think really trying to be flexible in kind of our service delivery system is going to be essential kind of moving forward. I think we have workforce challenges around having lack of school and childcare for our workforce, as well as fear around most of what we do at community mental health centers is in the community and in families' homes or individuals' homes. And I think navigating kind of the safety, you can have a site-based program and you can create kind of the safeguards with regard to that. But when you have people riding in your cars and you're going to their homes and there's all these new things. So it's really going to take an individualized approach around PPE as well as other safety factors to navigate that and provide that care. And that's why I think the other thing, just kind of on the same as what most of the speakers talked about, the use of telehealth. I mean, I think our system was surprised at the responsiveness of some of the folks with telehealth, but it's essential that we're able to continue that as well. So I think along with that, we need to take the time to learn from the unintended benefits from this crisis around adjusting policies, procedures, delivery, administrative burden. Sometimes we've created a large compliance-driven system, that there's a lot of boxes that are checked, but is it really accountable? And so I think we learned a lot about we can be accountable but have policies and procedures kind of drive that versus we have to have numerous site reviews that don't provide the depth of what we truly need. I think one of the other pieces that we're really worried about as a community is there's been a large loss of life, either from COVID or people have passed away from other health conditions, and people haven't been able to grieve in the way that they need to. And I think I'm really worried about that. And that's one of the areas that we're trying to do some community benefit around grief and loss. We'll be doing some Facebook kind of programs to kind of help with that and help navigate that. In the past 3 weeks, we've seen a significant increase in crisis calls, inpatient psychiatric hospitalizations, suicidal individuals, and children being removed due to abuse and neglect. The other component is just sitting here, my phone was binging because we got 3 referrals from law enforcement just this morning, and we have a jail diversion grant that we have. And so law enforcement, when they go out on a call, they can go out and they may not arrest them, they may not take them to the hospital, but they're concerned about them. They can do a referral to us, and then we do outreach. And that's been a huge success and component of diversion and various things. But then, you know, we found out just kind of on the funding track, you know, that grant is being cut totally for next fiscal year and moving forward. And I think, you know, there's a sense about investing in things that really make a difference that we have to systematically fund and not grant fund everything. We have to say, these are the things that work, so these are the things that we should invest in. Similar to the direct care wages, that we need to invest in those long-term, not just, you know, during this crisis. And I think the other thing is continuing to partner with the State Department. I think through this crisis, we've had some good results, and we need to continue to go through with that. And just be fluid in how we prepare. I mean, we can prepare, but what we found is that it's kind of one day at a time and 1 week at a time, and you project and you try to prepare, but we know that we have to be fluid enough to pivot and respond to whatever's in front of us. So I'll end there.
Connie, thank you, and thank you for your rapid fire presentation.
Sure.
Our next speaker is Ronald Taylor, MBA. Mr. Taylor is the president and CEO of the Detroit Area Agency on Aging, and is also was with the Aging Services Program as a specialist for the U.S. Department of Health and Human Services. Given the fact that I'm seeing numbers between 20 and 32% of COVID-19 related deaths are from nursing home residents, the view from the senior citizen perspective becomes crucial. So, Dr. Taylor, Mr. Taylor, the floor is yours.
Okay, and thank you so much, Dennis, and also Arnold, for the invitation to participate today. What I'd like to do is just essentially, the Detroit Area Agency on Aging is one of 16 area agencies on aging within the state of Michigan. And of the 16, there's 623 nationwide. And essentially our mission is to serve seniors that are 60 plus, also adults with disabilities, and also caregivers. If we can go to slide 2. Okay, essentially this slide provides an overview of the depth and the width of the services in which the area agencies on aging provide, along with the Detroit Area Agency on Aging. And we as a aging network, we built an infrastructure, and we've been able to form a backbone of home and community-based services that essentially deliver services for older adults and individuals with disabilities. And we consider ourselves to be a core health provider. And within our network, we provide a continuum of care services that are based on an assessment and levels of care as required by the participant. but we try to do so in a person-centered fashion or in a person-centered manner. If we can go to slide 3. As related to COVID-19, since everything changed, as the fellow presenters have indicated within their particular programs and systems. But for us, essentially what occurred is that all of our congregate sites, as far as our senior centers and then also our congregate meals programs and places in which we held our health promotion activities, all of those were shut down when we received the executive order and as the COVID-19 continued to spread. And so essentially what we had to do is we had to pivot and we had to transition as related to our service delivery for that population. And we were able to do so by providing curbside meal deliveries and working with a number of other entities such as the City of Detroit, faith-based organizations, and other community-based organizations to be able to get the meals out to the community. But what occurred and what happened is, and the other change within that system also was that for those individuals in which we provide in-home services to, there was what I'll say a great retraction of our ability to have face-to-face interactions or to go out and to go in the home and to check on individuals. And so that was scaled down a great deal. And so, issues started to come forward, such as social isolation and what could we do to address that. And we were able to do so by working with some of our partners in the Agent Network and also by redeploying and repurposing some of our internal staff members to essentially make telephone reassurance calls. We were making probably on a weekly basis up to maybe 400 to 450 calls per week just to check on individuals to make certain if there was a need for anything, if there was any groceries or any prescription drugs that they would require. And we implemented a new program to essentially be able to provide or to pick up those goods for those individuals if they indicated that they had a need. What also occurred is that we had a program pre-COVID-19. We were providing approximately 3,000 meals per day to residents within our plan in the service area. After COVID-19, that number jumped up to over 10,000 individuals in which we were providing services to on a weekly basis. And we were able to do so based upon what I'll say is the great community goodwill in which we received from a number of foundations, also businesses and volunteers within our area. So we were able to respond and to address some of the issues and address some of the needs from that perspective. And what we also witnessed is that some of our providers or some of our partners in the network that were providing, say, maybe adult daycare services prior to COVID-19, they repurposed themselves in regards to where they can actually assist in whether it was the delivery of meals and or helping with the telephone reassurance. And they also reimagined themselves in regards to actually moving their programs and services virtually. And we've seen a great interest from our community as far as in the participation in some of our caregiving services that have moved to a virtual environment, and also with some of our health and promotion programs, as far as some of the exercise programs that have moved to a virtual arena. And so it's been one of the great outcomes of this, but we still recognize that face-to-face and those interpersonal interactions, that they're crucial for our population and for our community. We've also have provided, we've been very fortunate to work with the state of Michigan through our state entity, the Aging and Adult Services Agency, along with other foundations, to be able to procure PPEs so that we can share them with our provider networks, especially those that are providing transportation services and also that are going, or our direct care workers that are going into our constituents' homes. So those have been some of the things in which we've done, or those have been some of the effects as far as the COVID-19. If we can go to slide 4. As far as our business, what we're seeing is that we are continuing to reimagine what our future is going to look like and what our role. We pretty much know what our role is going to be, but how we deliver our services is one of the questions in which we're asking ourselves. And I think it's a great opportunity because it gives you a sense of urgency to do new things and to be creative in how you approach things. Some of the things, as I've spoken about, is that we are moving to a virtual platform for a number of our services. And as many of the presenters have spoken about, we're also working to introduce a telehealth program. And we received support from the Michigan Health Endowment Fund to essentially design and to get a telehealth program implemented. And so we're hopeful to do that within the next 30 days. We've also begun to try to work as far as the re-engagement of our congregate programs. And as several of the presenters spoke about earlier, there are some anxieties as related to our senior constituents about coming back into a congregate setting. And also some of our providers, they've expressed some concerns. Throughout this process, it's been, one thing has been it's really hit home because we have had a couple of our senior centers that they've had participants that have passed away due to the COVID-19, and they've had team members that have come down with the infection, and so it's created another level of anxiety as related to, we want to make certain that we do this right, and we want to make certain that we do things in a safe and in a decent fashion for all involved. So we've been really working with them, and we've been following the CDC guidance, and also working with our state agency and with a couple of other entities such as our insurance company and others to develop a return to work plan that will take into account the safety of our constituents and then also the team members. One of the things in which I will say also as related to us moving forward, because we have ramped up and it's a good problem, but it's also something that's going to be a challenging problem for us, is because we have ramped up and we are, like I said, prior to COVID-19, we were serving 3,000 individuals through our meals program, and now that number is over 10,000. How do we transition and pivot from an emergency mode back to our new normal, which in our minds can't sustain at 10,000, but we're going to have to try to figure out how we continue to deliver services to those individuals that may be in need. So that's a situation in which we're examining, and which we're trying to take a bite out of the apple on. If we can go to slide 5.
Ron, we are right at the time limit. Could I ask you to conclude in a minute or less?
You sure can. Okay, just in a real topical fashion, as far as some of the health policy implications, there's several. I'll just ask that there's, as far as greater understanding and the development of policies that focus on social determinants of health. The second item, as far as the health policy implications, is that we must take a look at social isolation as being a health condition. I would also offer that there needs to be taken an examination as far as the inflexibility of, as far as some of the regulatory requirements that will make providing and accessing services a little easier. And the last thing, or the two other things in closing, is that we also need to focus on how we can assist as far as income and training our direct care workers. And in closing, I will say that we must also be on guard, and we must fight against ageism and the herd mentality that believes that it's okay to allow the sick, the old, and the injured to meet its natural course in nature. And so we just, the last slide will show as far as advocacy. And we just ask that, we're going to continue to advocate from our perspective. And it's just a great reminder that COVID-19 gave us is related to that, individuals like to reside in their communities, but staying in place. But we have to be serious about the services and the programs in which we can provide them that will allow them to remain in place and remain within their communities. That's it.
I thank you very much for your succinct presentation. Arnold, here I have to ask your advice. I'm showing us right at time. If we can accommodate this, I would suggest that we promise the legislators who have submitted questions that we will get written answers to them, and continue with the presentation with the final speaker, Dr. Mercatanti. Those who cannot stay on past 11 can pick it up on the recording. Does that work?
Yeah, I think that does work, and when Dr. Mercatanti is done, then we can see if those legislators are still on. We can check, and if they'd still like to have their questions answered at that time, we can do it then.
Okay. Then let me move on and introduce our next speaker, Dr. Annette Mercatanti. Dr. Mercatanti is a medical health officer for the St. Clair Health Department. And I will admit that I put Dr. Mercatanti on last because I thought the public health message was going to be the take-home message for today. My wife and I were traveling to the cottage, stopped at the Clare Rest area, and I'm estimating 40% of the people were wearing masks. It was kind of frightening, but that's your message. Dr. Mercatanti, the floor is yours.
Thank you so much. I'll try and be succinct. There's a lot to say. The slides that I sent out, could you put them up? I'll fly through them, and hopefully you can add them to what you send out. There's substantial notes as well that explain them. Yep. My first slide really just talks about core functioning of public health. The COVID pandemic is public health 101. It's what we were weaned on. It's what we do. Public health is cost effective. It has a dramatic impact on well-being, and I have a second graph that shows the large impact public health has had just on life expectancy, much more so, not to negate the value of the advances of health care, but public health has had a much more substantial impact on health. I'm on the second slide already. There you go. So core functioning. Social determinants of health are real important. It's, again, a core area. We do believe racism is a public health issue and crisis, and social determinants of health and health equity are built into everything we do. So it's a natural fit with everything that's going on, especially related to the discrepancies of the COVID impact. Next slide. Structure of public health in Michigan is convoluted and crazy. They say if you've seen one local health department, you've seen one local health department. We have 45 local health departments providing coverage for the whole state. Some are large, some are covering single counties, and as a result, there's wide variations. However, next slide, we do have a pretty robust public health code. It's considered probably, I would say, one of the envies of the nation. The public health structure allows for significant authority at the local level. And it provides 7 essential services that we have to provide. Only one of them being the infectious disease control. We are mandated to cover sexually transmitted diseases, immunizations, hearing and vision, public water supplies, groundwater, on-site wastewater, and food protection. So as you can imagine, in addition, there is no state health department. We are embedded in the Michigan Department of Health and Human Services, but we also report to LARA, it says DEQ, but EGLE, MDARD, all of these departments provide various funding and regulatory compliance that we work on. So next slide. This is a very helpful, excellent document that was put out in August 2018, reviews our local structure, our Michigan setup, as well as the funding. And just to be very brief, next slide, not to mention that we're underfunded. We're underfunded and we're underutilized. Public health is a remarkable asset, I think everywhere, but in our state, I want to say that I have never known such expert, professional, committed professional people working in public health at all levels. You have a vast amount of capacity here in your health departments, particularly your local health departments. And I really, and through this pandemic, we have fought to be heard. We have fought to continue, and in general, it's an asset that I don't want people to forget about. So let's get down to the pandemic. Next slide. We do have our infectious disease control mandate, as I mentioned, and when the pandemic hit in Michigan, we moved all of our assets, staffing, et cetera, into this capacity. We are the central tracking source, the local tracking source for the state. Every case that comes into the system that's been diagnosed is individually evaluated by our staff. Case investigations, contact tracing, it is all done locally and put into the system and validated. And I don't think there's any more data that's more accurate than what you're going to get from our local level. Let's go to the next slide. This is essentially, this is an old slide that shows the importance of communicable disease divisions in each local health department. Our key positions that we all have are listed here. And as I mentioned earlier, we took then, when the pandemic hit, all of our other positions, our sanitarians, our other nursing staff, and they were all working on case investigations, contact tracing, communications has been huge. So let's do the next slide. And to show you why it's complicated, this is just an example of funding for just communicable disease divisions in local health departments. You can see the wide variation in how this is funded. Each other area is funded similarly. And so you can see when we start shifting resources around to cover the need, things have become very complicated. Not to mention that the state in general has been providing a lot of complicated guidance as well, as far as amendments to our budget, etc. Next slide. So this is an example of what public health is doing. I mentioned the case investigations, a lot of work with facility and congregate settings, a lot of work with communication with our leaders, our public. Should we wear masks? Should we not wear masks? How many people? Do we have a commencement exercise? It has been endless. I mentioned data collection, analysis, display. Every local health department is doing this data locally and then struggling to align it with what is happening at the state level. We are the leads for the emergency operations centers in our communities, and not to mention the ongoing struggle with changes, the numerous executive orders. This has been a dramatic impact, and yet I can say that we're doing it. As we move into reopening, our next steps are going to be continuing to guide our community and our leadership for best practice. But most importantly, I think the discussion really is, what are we going to see next? And what we're going to see next is going to be visualized first and foremost at your local levels. And I would encourage all of you to work closely with your local health departments, because the first inkling of a problem, those outbreaks, those hot spots, and whether they're at community events or whether they're coming from industry, we're going to see those locally. And then as we progress, we'll be able to identify if they're moving, if the flame is being fired out, or whether we can keep it suppressed. And certainly I think all of our goals is to see this stay suppressed so that we don't see a large acceleration that's going to overwhelm our healthcare systems again. And so with that, I will stop and hopefully entertain further questions.
Thank you, Dr. Mercatante. Arnold, I'm going to look for you for direction. Do you want to go to questions, or do we wrap it up here?
Well, Senator Brinks had a question. And she's no longer with us. And so I know, let's see here. So I think we'll wrap it up and we'll try and address Senator Brinks's question directly with her. Okay?
The other ones I was seeing were comments rather than questions.
Yeah. And the first Senator Brinks question appears to be directed towards Dr. Megan. So,
right.
Okay.
Well, let me close it out by saying thank you to all of our presenters. The logistics did not work out well. That's my fault, and I apologize for that. I will close with this message. Someone told me that COVID-19 is a war between COVID-19 and humans. And the strength of COVID-19 is numbers. They have billions, if not hundreds of billions of soldiers. The strength of the human being side is intelligence. And if we want to use it, we can beat them. But as I said before, from my reading, about 40% of people wearing masks this weekend. That concerns me greatly. So again, I thank all of you for your interest. And Arnold, I'll turn it back to you for closing comments.
Well, again, we did run out of time, and so we'll try and address the questions directly. I want to thank all of our speakers for hanging in there with us for 2 hours. Greatly appreciated. Your information is of importance and timely as well. Thank you for all you're doing in your areas to combat this pandemic amongst our population, amongst our citizens. Thank you again to the Michigan Health Endowment Fund for their support, and my co-host, Dennis Paradise. This session has been taped and will be posted within the next week. Thank you again.